She presented to our OPD with complaints of swelling over the left upper back region since 6 months. So the patient was apparently all right 6 months back when she first noticed a swelling in her upper back region on the left side. It was insidious in onset and was initially the size of the lemon, which is around 3 into 3 centimeter when she first noticed it. The swelling was initially indolent in nature with rapid progression over the last 2 months to its current size of around 15 centimeter. The swelling is not associated with pain. There is no history of significant weight loss or loss of appetite. There is no history of redness or discharge from the overlying skin. There is no history of fever or night sweats. There is no history of restriction in the movement of shoulder joints or in bending or leaning. There is no history of limb weakness, numbness, or shooting pain in the upper limb. There is no history of any similar swellings elsewhere in the body. There is no history of breathing difficulty, cough, or shortness of breath. There is no history of prior radiation therapy. Past history. There is no history of similar complaints in the past. No history of chronic diseases like hypertension, diabetes, chronic artery disease, or tuberculosis. There is no history of previous surgeries. Personal history. She has a mixed diet. Her appetite is normal. Bowel and bladder habits are normal and regular. Her sleep is disturbed because she is unable to lie down in straight position. There is no history of smoking or alcohol intake. There are no known drug allergies. Family history. There are no similar complaints in the family. No history of malignancy in the family. Ma'am, can I proceed with general
No,
examination?
I will ask you a few questions here, Dr. Karthika.
Yes,
In
ma'am.
your history taking, you mentioned that she does not have any history of loss of weight and appetite.
Yes, ma'am.
What are you trying to assess by asking these questions?
Ma'am, loss
Okay,
of
let me reframe my question. By taking this history, you must have made up your, some differential must have been made up in your mind as to what we are dealing with.
Yes, ma'am.
Because it's a short history of 6 months, and you particularly said that there was a rapid growth in last 2 months. So when you're asking history of loss of weight, loss of appetite, fever, what are you trying to ask?
Ma'am, firstly, we are trying to establish the nutritional status of the patient, the general condition of the patient. How is she, if the swelling is affecting her deeply, that she's unable to eat and maintain her proper nutrition. And secondly, because of her age and rapid progression, we are thinking of a more inclined towards thinking of a malignant disease. So is the disease very advanced, which is causing her this cachectic status, which is hampering her weight?
Absolutely right. So if the cancer is advanced, then we will know by this history of loss of weight or loss of appetite. And the other thing is that if there is a rapid progression in last 2 months, then this could be an abscess also. But then if there is an abscess, then she will have some fever, weight loss, etc. So you're trying to, that is why you're asking all this. And you also asked the history of hypertension, diabetes, coronary artery disease. What is the significance?
She's a 71-year-old lady, and we are trying to establish if she has any other comorbidities for which she's taking any medications. She's on any blood thinners. If she's having any CAD history, she's on any blood thinners. So if we are going to do any procedure for establishing the diagnosis of this in the future, then we will have to, we will know what medications she is on and if we need to stop.
Very well answered. And another point that I wanted to make was that, you very clearly said that she does not have any pain. In case your patients have any pain, in the cases that you get in your exams or in routine clinic, then you must grade the pain using the VAS score. So that your examiner clearly understands what is the severity of pain. While you mentioned that she does not have pain, she has disturbed sleep because she's not able to lie down in a supine position. You could have said that she's not able to lie down in straight position.
Okay.
Right? Okay, proceed with the examination.
Okay, ma'am. So general examination. So examination is done in a well-lit room after taking verbal consent from the patient and maintaining adequate privacy. And the examination was done in sitting and supine position. The patient is conscious, cooperative, and well-oriented to time, place, and person. Her ECOG performance status is 1. She's a moderately built lady with a weight of 52 kgs and a height of 150 centimeters. Her BMI is 23.1. She's afebrile and her vitals are normal. The blood pressure is 80 beats per minute, which is regular and normal in volume. Blood pressure is 140 by 80 millimeters of mercury measured in the right arm in sitting position. Her respiratory rate is 18 per minute and the respiration is thoraco-abdominal. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or localized bony tenderness. Systemic examination, respiratory system. The lady is sitting comfortably, thoraco-abdominal respiration with symmetrical movements on both sides, and there are no dilated veins. On auscultation, bilateral equal air entry is heard. There are no added sounds. Cardiovascular system examination. On auscultation, heart sound 1 and 2 are heard. There is no murmur. Central nervous system examination. Her speech and memory is preserved. The muscle tone is normal and power is 5 by 5 in all 4 limbs. Per abdominal examination, the abdomen is soft, non-tender, and there is no hepatosplenomegaly. Ma'am, can I proceed with local examination?
Yes, please proceed.
Okay. On inspection, there is a single well-defined oval-shaped swelling of approximately 20 into 10 centimeters, which is present over the right upper thoracic paraspinal region, just inferior to the scapula. The surface of the swelling is smooth. The skin over the swelling is stretched out and tense. There is no visible scars, sinuses, dilated veins, or ulceration. There is no sign of muscle wasting or limb edema. No restriction of movement in the arm. On palpation, there is no local rise of temperature or tenderness noted. All findings of inspection are confirmed and the size of the swelling is 22 into 10 into 8 centimeters. It is located in the paraspinal region from T3 to L2 vertebra. The edges are well defined, the surface is smooth and the swelling is firm in consistency. It is fixed to the overlying skin and to the underlying muscles. There are no pulsations felt over the swelling. The shoulder joint movements are normal. Sensory examination is normal. On palpation of axillary lymph nodes on the left side, there is no palpable lymphadenopathy noted. On percussion, there is a dull note heard over the swelling. On auscultation, there is no bruit. This is the picture of the swelling, which is on the left side, paraspinal region.
Right side paraspinal region. Left side.
Left side.
Okay, in your findings, you said right side. So correct it. Make sure that your right and left should not be wrong.
Okay.
So Dr. Karthik, a few pointers here. One is that you have to always do the local examination first and then followed by systemic examination, as is being discussed in the chat also. You should always do that.
Okay.
And if the examiner, sometimes, there is a shortage of time and the examiner is, when you're coming to systemic examination and the examiner is trying to hurry up things, then you may simply say that all systemic examination is unremarkable.
Okay.
Additionally, I would say, when you mentioned about axillary lymph nodes in malignancy, in cancers, we have this mandatory thing of examining the supraclavicular lymph nodes always. So it is best to examine that also, as well as mention. I want to ask you, how did you check the fixity of this? How would you actually check the fixity of this mass to the underlying muscles? What are the principles of testing that?
So, ma'am, we will hold the swelling in our in the hand, like we will fix the swelling and we will move it from side to side. That is in perpendicular motion, perpendicular with the direction of the muscle fibers to check the fixity. And we can also ask the patient to lift their arms up above the head and see the movement of the swelling. If the swelling is moving with the movement of the muscle when we tell her to put her arm above. And also we will ask her to place her hands on the hip region and then put some pressure so that the muscle becomes taut. And when the muscle is taut, then also we will move the swelling in the perpendicular direction to see if the swelling has become fixed to the muscles or not.
Okay. And how do you check for the skin fixity?
Ma'am, we will check for the skin fixity by pinching the skin over the swelling and see if the skin pinching is possible, or if we can pinch the skin of the swelling, or if we cannot, that means that the skin overlying the swelling is fixed to the swelling.
Okay. So I want to give you one tip, before we proceed further. This is a virtual case presentation and you're showing a picture. While
Yes.
in examination, you will be writing the case history on a paper it is always a good idea to make a clinical diagram of the patient. And if on that clinical diagram, you must label it. You must label left, right, upper, lower correctly. And if possible, whatever are your palpation findings and your exact size, you must mention that size also.
Okay.
Yes.
Yes.
And for a big swelling like this, like in this picture, they have shown the hand which is being used to guide the scale. For your examination, I would say please carry two scales with you. For examining small lumps like the breast lumps, it is a good idea to carry vernier calipers. The examiners are also in a hurry to establish the diagnosis and take you forward towards discussion about the management. So if you make a good diagram, then they will not spend too much of time listening to your history and examination. That's a general rule that all of us have to follow. One more thing which I have observed few students doing a mistake is that for oral cavity examination, when they are trying to assess the size of the tumor, somebody just put a scale inside patient's mouth. Never do that. You can't put a scale or a steel scale inside somebody's mouth. Use the wooden spatula to mark the location, mark the size of the tumor, and then measure, take it out and measure it on the scale. Sometimes even your examiner will ask you this question: how did you measure the size of the tumor? Show me how did you measure it, right? So
Yes,
it's a good idea to do that. Okay, so going further, you've completed history as well as examination. Can you summarize the findings of your case and tell us, what are your differential diagnoses about this patient?
So to summarize my case, she's a 71-year-old postmenopausal lady with no comorbidities who presented with a rapidly progressive painless swelling over the left back region since 6 months. On examination, there is a single well-defined oval-shaped swelling in the left upper thoracic paraspinal region of size 22 into 10 into 8 centimeter, which is firm in consistency and fixed to the overlying skin and the underlying muscle.
Okay.
My differential diagnosis for this case would be uh, most probably malignancy of the upper thoracic paraspinal region, probably soft tissue sarcoma. My other differential diagnoses are cold abscess, a giant lipoma, and a bone tumor with soft tissue extension, primary bone tumor.
So, Karnika, I think that this is a giant lipoma.
Okay.
How do you refute that?
Ma'am, giant lipomas are usually mobile swellings, which are soft in consistency and generally do not have a rapid progressive course where they double or increase in size within a small time frame. And
Okay. And why not cold abscess?
ma'am, she does not have any, the swelling is not fluctuant. On percussion, it has a dull note, and it does not have a cystic or a variable consistency. So it is a solid swelling on percussion, and she does not have any other history of cough or weight loss or any fever, which could explain cold absence.
So let me give you one more tip here. If after your examination, you make up your mind that this is a sarcoma, then in a 71 years old lady, sometimes retrospectively also you will have to add some history. For example, you should have asked any history of radiation therapy in past. Because you are suspecting a sarcoma. What is radiation associated sarcomas?
Uh, Ma'am, radiation-associated sarcomas are those which arise in a field which has received sufficient doses of radiation therapy in the first setting. So we have the Kahan's criteria where we describe what is the radiation-induced malignancy. Says that a sufficient latency period of 10 to 40 years should be present between the first radiation therapy and development of the recurrent lesion. The new lesion should be biopsied and must be different from the primary lesion. And the alleged mucosa or the mucosal region should be normal at the time of first radiation therapy when it was delivered. And
Okay, what is the incidence of radiation associated malignancies?
it is less than 0.001%.
Okay, from where has this data come of 0.001? Which data has been used to identify the incidence? Earlier in Hodgkin's patients, we used to, a lot of patients used to get radiation therapy in a young age, and these patients would become normal adults. So from that, a lot of data about second malignancy or radiation-induced malignancy has come, and also from radiation exposure, like in the Chernobyl incident. From there, this has come.
Okay.
Which are the common malignancies which are known to occur in patients who had received mental or mini-mental kind of a radiation therapy for Hodgkin's lymphoma?
Angiosarcoma.
That is not the first. You have to think beyond sarcoma also. Breast cancer in women, thyroid cancer, lung cancer, esophageal cancers, right? And that is why in the modern era, when we are treating these patients with IMRT, IGRTs, we make an attempt, to reduce the radiation exposure to these areas. Okay, Dr. Karthika, so I would go further with your probable diagnosis of a soft tissue sarcoma. So how will you confirm your diagnosis and how will you further proceed with this patient?
So I have written the investigations here, ma'am. So I will proceed further. First, we will do the blood picture, blood profile of the patient. We will include the complete blood profile, kidney function test, liver function test, PT, APTT, and INR tests. For imaging of the primary, we'll do MRI of the spine. And to establish the diagnosis, we will do true-cut biopsy from the lesion under ultrasound guidance. And preferably, we would also like to do the ultrasound of the axilla and the abdomen and a HRCT of the thorax.
Okay, hold on. First of all, when you're saying MRI of the spine, say spine and paraspinal area because your tumor is mainly paraspinal. But why not simply do a CT scan? Why MRI? What advantage is it going to give you?
Ma'am, since the swelling is in the paraspinal region, we want to look at the communication with the nerves, the neurovascular bundles to see the surgical resectability in the future, and the involvement of the facial planes, the muscle which is underlying it. So,
Okay. And when it comes to biopsy, it is such a huge swelling. You can see it from 2 meters. What is the need of doing an ultrasound guided biopsy? You can simply poke a needle and take a sample.
Ma'am, since this is a large lesion, it will have a larger central necrotic zone. So to avoid the needle hitting the necrotic zone and missing the
Okay,
tissue for
understood. Tell me, what are the principles of doing biopsy in a patient where a sarcoma is suspected?
Mm. And the biopsy should be done from the surgeon who is going to operate in the future. And the
Why?
biopsy should,
Why? But anyone can do biopsy, and later on, even you and I can do biopsy, and later on, surgeon can plan surgery. What is the challenge? Why?
and we want to minimize the contamination to the compartments of the muscle. So if the swelling is in the anterior compartment, we don't want to the posterior compartment, we don't want to seed it or infect it because that will increase our resection.
Okay, but tell me one thing. This patient anyway has to undergo surgery because it's a huge mass, and she's very uncomfortable. She can't lie down straight, etc. So why not simply operate it? You do MRI. If it is resectable, then operate. Finished. Why do biopsy? Why do two procedures? Can we go ahead with surgery after doing imaging? So the answer to that, Kartika, is no. You would like to know what kind of swelling is this. Suppose this is a fibroma, then you do not need very big margins. But suppose it is fibromatosis, then you need very wide margins. So you would first like to establish diagnosis before going ahead. Never agree when your examiner is trying to mislead you. Would you have done that direct surgery in your OPD or in your clinics? No. So say no.
Okay.
So the diagnosis, histopathological diagnosis has to be established. So Kartika, tell me one thing. Give me names of 6 types of sarcomas.
Ma'am, angiosarcoma,
That seems to be a favorite, huh? Never start with it. Start with the common ones.
Ewing sarcoma,
Okay.
osteosarcoma,
Okay.
rhabdomyosarcoma,
Good. Liposarcoma, leiomyosarcoma,
leiomyosarcoma,
synovial sarcoma. Don't take so long.
clear cell sarcoma. Yes, ma'am.
Okay, okay. You've also written that you would like to do ultrasound of the axilla and abdomen. What is the intent? Why do you want to do that?
Ma'am, ultrasound of the axilla to know if there are any suspicious lymph nodes which need to be proven. And
Okay. So then it is best to say that ultrasound of the axilla and SOS if required any FLAC.
yes, yes, ma'am.
Which are the sarcomas? Sarcomas do not usually go to lymph nodes. Which ones go to lymph nodes?
Synovial sarcoma, clear cell sarcoma, epithelioid sarcoma, rhabdomyosarcoma, and angiosarcomas.
Okay. So generally, when we do biopsy from these lesions, the histopathologist just gives it at spindle cell neoplasm. This is the common report which comes. And then they ask for immunohistochemistry, IHC. So what is the principle of doing IHC?
To differentiate.
No, I know it is to differentiate different types of tumors. What is the principle of performing immunohistochemistry? They use certain antibodies tagged with certain stains.
Yes, ma'am. Yes, ma'am.
So the point that I'm trying to say is that the exam viva will not go straight away to the management. It will stop at various junctures. Okay, tell me which is the commonest or the most relevant or most confirmatory IHC marker which is used for Ewing sarcoma identification.
CD99.
Very good. Another one?
And CDX2.
No, NKX 2.2.
NKX2.
Liposarcoma, which one will you do? Okay, before that, you tell me which are the common IHC markers which are used for sarcomas to differentiate sarcoma from epithelial malignancy or lymphoma.
Cytokeratin.
No, cytokeratin is for epithelial. Vimentin, synaptophysin, desmin. These are the common ones. Okay, which is the one which is used for rhabdomyosarcoma, specific for rhabdomyosarcoma? Kartika, have you got disconnected with us?
No, ma'am.
Okay, you're there. Okay, which one would you use for rhabdomyosarcoma? I request that all of you should make a list of all the IHC markers which are relevant for all tumors, and you should know it, desmin and myogenin. Which one is used for GIST? We request everyone to mute except for Kartika.
CKIT.
CKIT, CD117.
CD117.
Which one is used for synovial sarcoma confirmation?
S18, SSX, S18.
SS18, synovial sarcoma 18, SSX fusion.
Yes.
Okay. So when you are saying that, you should always say that after true-cut biopsy, if required, we will do immunohistochemistry markers to identify the subtype of sarcoma. Is it important for us to know the subtypes of sarcoma?
Yes, ma'am, to know if it is a high grade or a low grade lesion.
And also we have to understand how much margins are required. For example, myxofibrosarcoma will require much bigger margins. Fibromatosis will require much bigger margins. Or there are tumors where you would think more of lymph node dissection. So you would like to know the histological subtype.
Okay. And neoadjuvant chemotherapy also, if like some tumors like Ewing's will require neoadjuvant.
So coming back to our patient, yes, are you thinking that this is Ewing sarcoma?
No, ma'am, not this
Then
patient.
don't talk about Ewing sarcoma. Don't put your foot into your mouth. Yeah. Okay. So which are the common sarcomas, adult sarcomas that you just now talked about, synovial, lipo, which is very which is very chemosensitive, most chemosensitive? Is there any gradation? I'm not talking about osteosarcoma. I'm not talking about rhabdomyosarcoma. I'm not talking about Ewing sarcoma. I'm not talking about all three of them.
Ma'am, clear cell and synovial.
No, not clear, but synovial sarcoma. So no, synovial sarcomas are more chemosensitive, I'm sorry, as compared to the other sarcomas. So how will you proceed with the treatment of this patient?
So, we will get the MRI done. So I have included, ma'am, the MRI and the biopsy
Okay,
of this
go ahead,
patient.
go ahead.
So, the MRI of this patient, there is a large,
Okay, tell me
well-defined
after the MRI, is it resectable or unresectable?
It is resectable because the MRI states that there is no invasion into the adjacent bony structures or neurovascular bundles, which is noted. And it is an intramuscular neoplasm.
Okay,
So,
so how will you proceed with this patient? I read this MRI report. I'm sure everyone has read it. And the biopsy is myxoid liposarcoma.
yes, ma'am.
What is very specific about myxoid liposarcoma in terms of radiation sensitivity?
Ma'am, it is it is one of the most radiosensitive sarcomas.
Correct. It is one of the most radiosensitive sarcomas. Sometimes in retroperitoneal sarcomas, we give preoperative radiation therapy. So in case preoperative radiation therapy is given for myxoid liposarcoma, then the dose is 36 gray in 20 fractions and not 45 gray. So there is a dose de-escalation which is possible. Okay,
Yes.
Kartika, coming back to our patient. So you say that it is a large tumor, but it is resectable and her general condition is also
Yes.
good.
Yes.
So then how will you proceed?
Ma'am, we will send the patient to the surgical oncologist for surgical resection of the swelling.
You should say that I will discuss the case in multidisciplinary tumor
Yes.
board, and we would strongly consider surgical
Yes.
resection for this patient. What are the principles of surgery? Will they do just an excisional biopsy, or how much margin they have to take?
Ma'am, they will do wide local excision with a 5 centimeter margins from the swelling filings.
Where will you
And
get
for
5 centimeter margins here?
2 to 3 centimeters.
Which is what is the minimum margin which is required in this kind of a sarcoma? See, we are not talking about extremity sarcoma. You are constrained by the normal tissues all around. What is the minimum margin below which you will say, okay, the margins are close when you read the histopathology report? No margin, no tumor on the ink margin, 0.5, 0.1, 7 millimeter, 1 centimeter, how much? Quickly.
Ma'am, 1 centimeter.
1 centimeter.
Yes.
In extremity sarcoma, you need 5 centimeter margin. Do you always get 5 centimeter margin in extremity sarcoma? You don't get it.
Yes.
You have to excise but clear margins, preferably more than a centimeter. What are the indications of, suppose this patient undergoes surgery and the histopathology also shows that it is a 20 into 15 into 8 centimeter mass and they are able to remove it en bloc and the margins are all more than 1 centimeter and she's a 72 years old lady, then what will you do further? You will ask her to come for follow-up or would she require any other treatment?
She would require adjuvant radiation therapy.
Why?
Because
Why?
the size of the tumor is 20 centimeters. So any tumor which is more than 5 centimeter has a higher risk of local recurrence. So we would consider giving her adjuvant radiation therapy. And also depending upon the final histopathology, if it is a high-grade tumor, um, then also we would consider adjuvant radiation therapy. And also if it's a deep-seated tumor, um, uh, if there is invasion of superficial fascia, if there's a deep-seated tumor, then, or if it is a recurrent setting, then also we would give her adjuvant radiation therapy.
So, Kartika, if this patient lands up in your OPD after doing surgery and her stitches are healed, and you've counseled her for radiation therapy and she agrees to undergo radiation therapy, then how will you proceed with radiation therapy planning or simulation in this patient? What are the basic principles that you're going to follow? Tell me about, I'm giving you a hint which the examiner will not give you. Positioning, immobilization, simulation, tell me everything.
Ma'am, since this is a back swelling, we will position the patient in the prone position. We will give her suitable headrest, a head pillow or a headrest to immobilize the head and to provide her proper cushioning for breathing support.
Prone
Uh,
pillow.
a prone pillow. And we will ask her to elevate her hands above the head. And also,
What is the
we
need?
would,
Let her be comfortable. She's an old lady. Let her keep the hands by the side.
um, ma'am, we will be targeting the swelling from the side. So we want to avoid the arms getting uh, the dose of unnecessary dose of radiation therapy. So we will remove the arms
Okay.
from our radiation sides.
Okay.
And in the post-op setting, we will put a scar, we will put a
No, you
copper
said
wire.
prone. You said prone. You said prone pillow.
We
What
will,
else?
the arms will be above. We
Arms.
will we will immobilize her with a suitable thermoplastic mold or a vac lock as per institutional
Okay.
protocols.
Good. Hmm.
And
Then.
then we will use a copper wire to mark the scar. We will
Okay.
also use a bolus over the scar. The width of the width of the bolus will be 0.5 centimeters, and the dimensions will be 3 centimeters from the scar. And
Hold on. Hold on. Thickness of the bolus will be 0.5. Width
thickness
will
will
be
be
3 to 4
0.5.
centimeter. What
Width
is
will
the
be,
need? What is the need? The surgeon says that he has not done any contamination. You still want to give a bolus to the scar?
yes, ma'am.
Why? Because scar recurrences are known to occur in soft tissue sarcoma. Which other tumors where we always put a bolus, around the scar?
Parotid tumors.
Parotid. Okay, good. Go ahead.
Um, So we will put the scar, we'll put the bolus, and then we will take her simulation CT scan now. And in the simulation CT scan, our field will be from below the clavicle up till the superior iliac spine. Our slice thickness will be 5 millimeter, 2.5 to 5 millimeters. And we will give her contrast as per her creatinine clearance and her weight to delineate the normal vessels. And yes.
Kartika, suppose you're working in a center where, CT-based simulation is not available. You have to do X-ray-based simulation and treat her with 2D RT. Would you just send her away saying that it is just not possible? Or is there any option of giving 2D-based radiation therapy? And what will be your beam arrangement if you're doing a 2D-based radiation?
We will give tangential fields for the treatment of this tumors, and we can use 2D to treat the tumor as well, ma'am.
So never make a mistake of saying that we will give a direct and facing PA field, posterior-anterior field. No, that will be blunder. Because if we give her a direct posterior field, because this tumor will make you think that a direct posterior beam is good, but don't forget the underlying lung, heart, etc. So you will treat it with bilateral tangential fields. Or electrons may be, but electrons may also not be a very great idea. Okay, Kartika, suppose you have the facility of both 2D RT as well as IMRT, IGRT. Then how will you explain the patient? What are the advantages of IMRT in this patient over 2D RT?
Ma'am, because it is a paraspinal region, we have the cord just lying just adjacent to our target volume. So IMRT will give us additional benefit of sparing the spinal cord, and also the underlying ribs, the underlying lung, we will be able to spare better with IMRT as compared to 2D. So we can
What
counsel.
else? Conformality, you said OAR sparing. What else? Homogeneity. Homogeneous. You'll be able to maintain the homogeneity because you have a large target volume. And if you're doing IMRT, ideally it has to be accompanied with image guided RT also because it's a large volume and you're positioning the patient prone.
Yes.
What are the doses of radiation therapy which you will aim to give this patient? Suppose it is R0 resection, R1 resection, or R2 resection.
And if it is R0 resection, we will give her 60 gray at 1.8 to 2 gray per fractions for 30 fractions. If it is R1 resection, we will give her 64 to 66 gray at 1.8 to 2 gray per fraction. And if it is R2 resection, we will aim for 66 to 70 gray at 1.8 to 2 gray per fraction.
Suppose this is a low-grade sarcoma. Suppose this is a low-grade sarcoma, then what will be the dose of radiation therapy that you would aim? Would you still give 60 gray for a R0 resection?
Yes, ma'am.
Then what dose will you give?
60 gray, same.
My first question is that in case this is a low-grade sarcoma, would you still give a radiation therapy?
Yes, ma'am. Because of the size criteria, we will still give her radiation therapy.
Agreed. And what doses will you give?
Ma'am, same doses for R0, it will be 60 gray, ma'am.
No, beta. If it is a low-grade sarcoma, then you will give, for a low-grade R0, you will give 54 to 56 gray. Considering the location and size of the tumor, always mention 60 gray in 30 fractions while respecting the OAR tolerances. Because only after the planning, you will know whether you are able to push that much of doses or not. So, Kartika, in case this patient is undergoing radiation therapy, what are the kind of toxicities that you are expecting that the patient will face, for which you will, prepare her?
So, ma'am, her acute toxicities will be skin toxicity, that will be dermatitis.
Can
And
you tell me the grades of radiation dermatitis?
ma'am, grade 1 will be faint erythema. Grade 2 will be moderate erythema with dry desquamation. And um, um, grade 3 will be ma'am, grade 3 will be moist desquamation, which bleeds, which with spontaneous bleeding. And grade 4 will be skin necrosis, ulceration, and
Okay, what are the grades of pneumonitis? How do you grade pneumonitis? Radiation pneumonitis.
grade 1 will be asymptomatic.
Very good.
Grade 2 will be
So how will you know whether it is a
uh,
asymptomatic pneumonitis or not? Asymptomatic pneumonitis, which is apparent on imaging. Correct.
yes, ma'am, imaging.
Grade 2,
Yes, ma'am. Grade 2 will be, yes, ma'am.
go ahead.
Grade 2 will be, ma'am, symptomatic, in which the clinical features could be dry cough, shortness of breath. Grade 2 is symptomatic patient which requires medical intervention. Grade 3 is severe symptoms requiring oxygen support. Grade 4 will be severe respiratory distress requiring ventilation or ventilatory support.
So
And
if you get a
grade 5.
patient, if you get, when does patient get symptoms of pneumonitis? Suppose this patient completes radiation on 1st of July. Then is radiation pneumonitis an acute feature that will happen while she's on radiation? Is it subacute or is it generally delayed? What is the median
It is
time interval for radiation? It is very good, subacute. So what is the median time interval when the symptoms generally appear for these patients?
Ma'am, usually 1 to 2 months after completion of radiation therapy.
Okay. Suppose there's a patient who comes to you in the OPD and she's having breathlessness and she says, Doctor, I was fine after completion of radiation therapy and I completed my radiation 2 months back, but I'm continuously having this dry hacking cough and I get breathless very easily. You do a CT scan and you think that it is, coming in the radiation fields and you think that it is radiation pneumonitis, then how will you actually assess clinically her the severity of her symptoms? What all clinical parameters will you look at?
Uh, Ma'am, she will be tachypneic.
Tachypneic,
She will
very
have
nice.
a shortness of breath.
You will look
Where
at her
on
the
auscultation,
saturation.
we will. Yes, ma'am.
Saturation. What will you find on
Yes, ma'am.
auscultation?
We will find fine crepes on auscultation.
Okay. What else? How will you assess the severity? 3 minutes walk test. We all did that
Yes.
walk test when when we were in the COVID era. Yeah. So you will note her saturation. Say, suppose her saturation is 96%. You will make her walk for 3 minutes, again check it. If it is falling down by approximately 4 to 5%, then you know. What is the management? What are the grades of management of radiation pneumonitis? Treatment options. Suppose it is mild radiation pneumonitis, what will you do? Nothing.
Ma'am, we will give a supportive management,
Like,
which includes
okay. Suppose it is moderate to severe.
antitussives or
Very good. Very good. Suppose it is moderate, then what will you do? Inhalational steroids?
steroids is the mainstay of treatment. So we, ma'am, for mild to for moderate, we will give oral steroids.
Okay.
For
What is
severe, we
the
will give
what is the
IV
dose of
steroids.
what is the dose of radiation? What is the dose of steroids, and which steroid will you use?
Ma'am, we will use methylprednisolone. Our
Yes,
dose will be 1 to 2 mg per kg.
1 milligram. 1 milligram per kg body weight is what you will start with.
Yes, ma'am.
And then you have to taper it down very, very slowly.
Yes, ma'am.
Okay. Kartika, you said that in case this patient is undergoing 2D radiation therapy, then you will use tangential portals. So in your tangential portals, I'm very sure that you will use wedges to make the distribution as homogeneous as possible. I would like to know where will be the thicker end of the wedges and where will be thin end or heel of the wedges in case you are doing a bitangential planning, you 2D RT for this patient.
So, ma'am, the heel end will be towards the superiorly towards the lungs. We will keep the heel end.
Superiorly towards the lungs. Okay, you have positioned the patient prone. So the lungs are actually anterior.
Uh,
You will use two fields, medial tangential and lateral tangential. So medial tangential field will come from towards the spine, and lateral tangential will come from somewhere from the posterior axillary line, right? Why are
yes,
we
ma'am.
using tangential fields? We are using tangential fields to avoid the radiation dose going to the lung. So now tell me,
Yes.
suppose your field length is 20 centimeter and your field width is approximately 8 centimeter. You are using wedges here as tissue compensators. So the thick end of the wedges will be towards air and the thin end will be towards the spine. Make a dose distribution and try to understand. Yes, then it will be clearer to you.
Okay.
Have you heard of anything which is called as breast cone?
Yes, ma'am.
Where is it used?
And ma'am, whole breast radiation therapy. Uh, in
Good.
the 2D era when we were treating.
I know it is very difficult for your generation to understand, especially students who have not worked on the cobalt to understand the cobalt accessories. But when we used to treat patients on cobalt, telecobalt for breast cancer, we would use these breast cones. So the breast cones worked on the principle that the central axis of the beam goes always straight and is non-divergent. And we are trying to avoid the non-divergent beam so that the divergent radiation should not go into the lung. So here you can almost imagine that this, when you're giving 2D radiation therapy to this patient, it is like you're treating the chest wall after MRM. So you will not have that mound, you will have the flat area, and the goal is still the same. The goal here is to spare the underlying lung and liver, whatever is coming in the field. So you also have this option of you doing the half beam block by using the rest cone so that the diversion beam does not go inside. Dr. Karthika, you also mentioned that you will use a bolus on the scar. What is bolus? Can you explain?
So, ma'am, bolus is a tissue equivalent material which is placed over the surface of the skin to bring the to increase the surface dose.
Okay, perfect. And what are the common materials which are used as bolus?
Ma'am, we can use wax bolus. We can use gel bolus. We can also use cotton dipped in water, soaked in water as a bolus.
Okay, okay, good. Okay, coming back to the original treatment plan for this patient. Suppose this patient also completes a radiation therapy and she does well. What is the role of uh, adjuvant chemotherapy? I also want to ask you before this one more question, that some of the students in the chat box had written that we would give neoadjuvant chemotherapy followed by surgery. Would you have considered what is the role, what is the evidence for using neoadjuvant chemotherapy in a case of soft tissue sarcoma, which is large in size and maybe unresectable? If it is resectable, then maybe surgery. If it is unresectable, or you think that the surgical defect would be very large, is there any role of neoadjuvant chemotherapy? Which drugs will you use? How many cycles? How do you assess response?
And we have the SMAC meta-analysis, which tells us the benefit of chemotherapy. However, there are no like strict guidelines for giving neoadjuvant chemotherapy. We can consider in patients who have very large, bulky tumors in the neoadjuvant setting to improve the resectability rate. We can use. The drugs that we can use is adriamycin and ifosfamide in the neoadjuvant setting.
So, Karthika, let me frame the answer for you. If I am the student, then I will say that there is no proven role of neoadjuvant chemotherapy in a soft tissue sarcoma. If it is unresectable and the surgeon thinks that the surgeon cannot resect it or achieve R0 resection, then we can consider on case by case basis after a discussion in a multidisciplinary tumor board. But considering that she's a 72 years old lady, we would avoid neoadjuvant chemotherapy as much as possible. Suppose, okay, tell me about adjuvant chemotherapy. Would you send her for adjuvant chemotherapy?
Again, there is no guide, there is no clear cut rule,
What are
but
the
we
indications
can
of no?
consider in
Okay.
patient.
No, don't use these words like can. Can means we are uncertain. Yeah. What are the indications of using
Okay.
adjuvant chemotherapy in a soft tissue sarcoma like this one? What are the indications?
Ma'am, high grade tumors,
Very good. High grade sarcomas. Use
size,
the word sarcoma, beta.
high,
High grade sarcoma.
high grade sarcomas, large tumors, like more than 5 centimeters, or preferably 8 to 10 centimeter tumors, which are large, and also deep seated tumors, or tumors which are not completely resected. In those cases, in these cases, adjuvant chemotherapy.
So the answer is not correct. I'll give you the right answer. Adjuvant chemotherapy is reserved for tumors which are large, high grade, recurrent, and in young patients, not in old patients. So, which are the drugs which are commonly used for adjuvant chemotherapy in soft tissue sarcomas?
Adriamycin, ifosfamide, and along with mesna,
Okay,
these two drugs are
good,
used.
good, good, good. What is the common toxicity of ifosfamide for which you are adding mesna?
Cystitis.
Yes, cystitis, hemorrhagic cystitis.
Hemorrhages.
And yes, okay, good, go ahead. Suppose, Kartika, this was a normally we do in exam, it is very unlikely that you will get a case of chest wall sarcoma. It is more likely that if anyone gets a case of soft tissue sarcoma of extremity. Suppose this was a 50 years old gentleman with a 20 centimeter mass in the medial aspect of the thigh. Forget thigh. Suppose it was in the leg, below knee. Then how will you manage this patient? And what is the goal of treatment when you're managing a extremity soft tissue sarcoma?
Um, Ma'am, limb conservation or limb sparing is our goal of treatment, and we want to avoid amputation as to for these patients. And in the management, we will first start with the imaging of the primary and establish the diagnosis by doing a biopsy from the lesion to confirm the nature of
Hold on, hold on, hold on.
the
So
disease.
the treatment, the intent of the treatment will be curative. Yes,
Yes,
in a
okay.
non-metastatic setting. And you will say that you would like to achieve an optimal local control rate while maintaining the limb function. You forgot when talking about the cure and control rate. We have to achieve both,
Yes,
right? Suppose there is a
yes,
patient where surgeon says that, this tumor is fixed to the underlying bone and I don't think I can resect it. I can never get clear margins, or it is fixed to the underlying vessels, nerves, etc. and wants to say offer an amputation to a 40 years old gentleman and asks you that if you have any option of giving any form of neoadjuvant chemotherapy and radiation therapy, then what is the preferred neoadjuvant approach in a borderline unresectable soft tissue sarcoma?
we can give we will give pre-op radiation therapy for in borderline resectable patients to increase the resectability rate and achieve a R0 resection.
I
And
really like the way you framed your answer, because you initially said we can, but then you quickly changed to we will. Yes, that's absolutely right. So is there any randomized trial which has looked at preoperative versus postoperative radiation therapy in soft tissue sarcomas?
ma'am, there is a trial by Rosenberg et al. Which have randomized patients into oh, there is a trial by O'Sullivan et al.
Good.
Which has randomized patients into pre-op versus post-op radiation therapy. This trial has shown that the local control benefits with pre-op versus post-op radiation therapy are same, along with the toxicities. However, the nature of toxicities between the pre-op and the post-op radiation therapy are different, but the local control rates and the survival rates are same between the
So
two.
what is the difference? Why should we consider preoperative radiation therapy?
So, ma'am, pre-op radiation therapy has a radiobiological benefit. That is, the hypoxia will be less in these tumors. Our radiation volumes will be smaller than in the post-op setting, and um, uh, we have a chance. We have more chance. We have the chance of achieving R0 resection if we are giving pre-op radiation therapy, and we are decreasing long-term side effects, which are higher in post-op radiation therapy.
Which are the side effects which increase in patients who are given preoperative radiation therapy?
Ma'am, the acute side effects or wound complications are higher with pre-op radiation therapy.
So generally, if I have to counsel a patient, then I will say, would you like to have more acute complications, or would you always like to live with a lot of late side effects? It is better to have small side effects now than to have more side effects all your life. So that is why preoperative radiation therapy is preferred. Suppose, Kartika, you are called to see a patient in a MDT where there is a large tumor, large sarcoma, which is, say, in thigh or in arm, and the surgeon is planning resection. It is resectable, non-metastatic disease. And you have this option of either doing intraoperative brachytherapy, perioperative brachytherapy versus postoperative EBRT, then what do you prefer and why?
Ma'am,
I'm just muting
perioperative.
myself for a minute. Huh? Give me a minute, somebody. I'm sorry. Yes, yes, Kartika.
Ma'am, we will be inclined towards giving perioperative brachytherapy for the patient, ma'am.
Okay. So can you tell me how many how many planes are generally put up in while doing interstitial brachytherapy for soft tissue sarcoma? It's a single plane, two plane,
Single
three.
plane implant.
Majority cases, it's a single plane implant. What is the intercatheter distance that you maintain between while doing the implant?
Uh, 1 centimeter, 1 centimeter generally.
Always give a range. 0.8 to
1 to
1.2 centimeter. Which is the brachytherapy system? Paris, Manchester. Which system will you follow while doing the interstitial brachytherapy?
And we'll follow the Paris system.
Can you tell me two basic rules of Paris system?
Ma'am, the source will be the activity of the source will be linear, and
Catheter spacing?
the catheter spacing will be equidistant. Uh, and for larger implants, we can use single or a double plane implants. In this system, we also prescribe the dose based on the basal points. And
Where is basal dose point located, Kartika?
basal dose point is the point which is receiving the minimum dose between the two maximum points. Like
No. So you have to very clearly say that if you are doing a single plane implant using Paris system, then all the catheters have to be in the same plane. They cannot be in different planes, first of all. And then the catheters will be equispaced, 0.8 to 1.2 centimeter. In case our target volume is thicker, then we will try to achieve a triangular geometry by following 2 or 3 plane implants. The second plane, the first plane will have all the catheters equispaced, and in the second plane, the catheters will be positioned in such a way that they are forming equilateral triangle with a deeper plane. The basal dose point is located at the center of this triangle where the doses are prescribed. How is it different from Manchester? Tell me one difference between Paris and Manchester system. One basic difference in how the needles or catheters are put in the interstitial brachytherapy.
We have crossing. We don't have crossing of the applicators and the.
Very good. So you're there, but you're not saying it correctly. We will not put the crossing needle at the edge. Why in the Manchester system were they putting the crossing needles at the edge of the implant?
Ma'am, because the ends of the implants were receiving less dose of radiation therapy, so to increase
Compensate for
the
that. To compensate for that. Why were they getting lesser dose? Because the scatter dose in that area was less. So that is why to compensate for that, we were always putting a crossing needle, which we do not put in the Paris system. Then how do we take care of it in Paris system? The doses are still less at the edge of the implant. By doing optimization. Now we are using a combination of Paris system. Paris system is used for achieving a particular geometry of the implant, while the planning is done on the computers. So you can always increase the dwell time to compensate for that missing crossover needle. So we do not follow Manchester system. If anyone asks in the exam, we follow the Paris system of doing interstitial brachytherapy. Please read about these systems because if you get a case of sarcoma, they will certainly ask you. Last few questions, Kartika, about sarcoma. What are the radiological appearances of Ewing sarcoma?
Ma'am, on X-ray, it will be a permeative lytic lesion for Ewing sarcoma. They will.
Don't start.
Okay.
Where is it located?
Metaphysis of long bones.
Okay.
Ewing sarcoma.
Describe the radiological appearance.
There will be a permeative lytic lesion with a periosteal reaction that will resemble a onion peel appearance, and we will also have a periosteal reaction in the form of Codman's triangle.
Okay.
Because of the new periosteal bone formation, and
Which are the bones which are commonly affected by Ewing sarcoma? Where does it occur? Which bones?
Ma'am, the long bones, namely the femur, the tibia, or the humerus, is most commonly affected.
Fibula. Fibula. Okay. So lower limb bones as well as humerus. It's a diaphyseal tumor, not metaphyseal tumor. You have to know that. Suppose you get a 10 years old child with Ewing sarcoma of the femur. Then after the workup is done and it is a non-metastatic disease, then how will you proceed and what will be your, give me just brief framework about how will you treat this patient?
Ma'am,
Amputation?
No, ma'am.
Say never.
Yes.
Okay.
Ma'am, we will first start with the neoadjuvant chemotherapy for this patient.
Which drugs will you use and how many cycles or over how many weeks? And it is not called neoadjuvant chemotherapy. It is called induction chemotherapy. Okay.
Ma'am, in the induction part, we will use 9 cycles of VDC and IE regimen, which is vincristine,
Very good. Doxorubicin,
cyclophosphamide, etoposide, and ifosfamide.
Okay. After about 10 weeks of induction chemotherapy, you will reassess the response. If in case there is a favorable response, will you give radiation therapy or
Surgical resection? We will if
amputation?
No, ma'am, wide local excision.
Excision, wide local excision. But
and
then
followed by
no, not followed by wide local excision and reconstruction, darling.
reconstruction. Yes, ma'am.
Suitable reconstruction has to be done. It's a small child. And preferably you will put an expandable prosthesis for this patient. What are the indications of giving postoperative radiation therapy in a Ewing sarcoma?
Ma'am, if there is any R1 or R2 resection,
Very
if
good.
if on histopathological examination, if it is less than 90% necrosis.
Okay, very good.
Poor
response to chemotherapy and R1, R2 resections. Okay, yes. Very good. Suppose you get a patient of pelvic sarcoma. Suppose it's a 10 years old child with a pelvic sarcoma and surgical resection is not possible because surgical resection would entail hemipelvectomy or extended hemipelvectomy. Then what will be the doses of radiation therapy that you would like to achieve for an unresectable pelvic Ewing sarcoma?
Mm, 66 to 70 gray.
Okay. 60, very good. Very well answered.
128 to 2 gray per fraction.
Okay. We have to all know about the randomized trial which has been done at TMH, Laskar et al., where they've shown that higher dose radiation therapy improves the chances of local control rate for these patients. Somebody's written in the chat box that why not do resection after an R1 resection? Generally, in a bone sarcoma, resurgery is almost not possible. And somebody's written that if you're giving such high doses, then the toxicities will be more. Absolutely. When we're doing dose escalation, the toxicities are expected to be more. But then the 70 gray is not given to the very big volume. It is to that final coned down volume that you will escalate your doses to. Dr. Kanu, are you there? I think Kanu must be having his dinner. After putting all of us. Yes, Kanu.
Madam, 1 minute, he's coming. Just point out.
Somebody's written 2 PTVs, no, maybe 2, not only 2, they can be 3 PTVs also. Phase 1, phase 2, phase 3.
Just tell.
Hello, ma'am.
Yes.
Actually, sir went out. Just wait for 5
No problem. No problem. I just want to know, should we continue or how much time do we have? Otherwise, I think we've done a lot of basic discussion has been done.
Ma'am, thank you, madam.
Thank you, Kanu. I was just joking that you put all of us to work and you've gone for dinner or a nap.
Madam.
We were joking that you've gone for a nap after putting all of us to do the work.
Only. Madam, anything you want to add more, madam?
No, I think a good discussion, a comprehensive discussion about the whole sarcoma diagnosis, types, IHC markers, workup, principles of management, principles of radiation therapy, radiation toxicity, some discussion about extremity sarcomas, bone sarcomas. I think we've covered almost everything.
Thank you, ma'am. Thank you.
No, thanks to you, Karan.
Thank you, Dr. Kartika.
Thank you.
I think let's give Kartika a chance to ask something if she's not understood anything. Kartika.
Any students, if you want something, just ask in the group in chat. We will answer.
One question which I could not properly answer, which came in the chat, I was constantly looking at the chat, was regarding the difference between Paris and Manchester system of brachytherapy. It is hard to explain it without making a diagram.
So now though we are going to discuss about the brachyoscopy. I think all things will come in that group.
Okay, very good. So Kanu, over to you. Thank you, Dr. Karthik. Very well presented.
Thank you,
everyone.
Thank you.
Sir.
Dr. Manav has written a very valid point in the chat box that when you're doing a soft tissue sarcoma external beam radiation planning, we should never give full circumferential radiation therapy. We have to spare a lymphatic corridor, which means we have to spare minimum 2 to 3 centimeter of the circumference to prevent the lymphedema in future. Very valid point. Thank you, Dr. Manav.
Thank you, ma'am. Thank you. So, next OSCE program is there. OSCE and brachytherapy instruments, systems, and everything. We have Dr. Parthasarathi Bhattacharya. He is a senior radiation oncologist in Mahatma Gandhi Cancer Hospital, Visakhapatnam. He is very much interested in the brachytherapy and brachytherapy procedures. And Dr. Priya Alice, she will answer the questions and identify the all brachy instruments. Over to Dr. Bhattacharya, please. Mute. Video. Okay. Yeah, am I audible? So we'll be starting a discussion. Yeah, we'll be starting a discussion on the OSCE brachytherapy instruments.
So basically, we'll have a few instruments and few implant procedures. If anyone is not seen those procedures images, they can ask us questions or put questions in the chat box. So the first thing we want to continue is, so first of all, this is an applicator. Definitely it is an ICRT applicator. So first of all, we'll try to know the name of this applicator, identify it.
Sir, this is the
Yeah, so there are some glitch in it. So first question will be, what is this applicator?
Sir, this is a Fletcher suit.
sound.
This is a Fletcher suit intracavitary brachytherapy applicator.
So Fletcher suit intercavitary brachytherapy applicator. So you can see two awards, one intrauterine tandem, and there is another thing that is depicted in. What is that?
Sir, that is a rectal space.
And what is the use of this putting rectal spacer?
The rectal spacer is used to displace the rectum from field of radiation.
So how do you it is useful for all patients, or suppose we are spacing it with the gauge piece, the anterior and posterior packing is done. So how is it different from using a rectal spacer?
The rectal spacer is used instead of posterior vaginal packing. If you are doing adequate posterior vaginal packing, rectal spacer can be avoided. If you are using a rectal spacer, you can limit your posterior vaginal packing, and you can do the anterior vaginal packing to fix the applicator.
Okay, so there are two things here. So first of all, you should know there is an option of fixing the applicator with the base plate. The various companies will be providing us. And there is also an option of buying shielded awards. There is a Fletcher suit shielded awards. You can see some shields. If I have the diagrams, I can show you. But there are shields in the posterior part of the award, which shields the part of anterior and posterior part, and it shields part of the bladder and rectum. Instead of that, we can use the vaginal packings. Usually about 1 centimeter of vaginal packing. Too much vaginal packing should not be done, because if you are doing too much vaginal packing, it means that you are not utilized the optimum size of award for such patients. Now, in our two-dimensional era, the rectal spacers were also used. It is having some marks with it, with the rectum marked as 1 to 5, the rectal and sigmoid points, and those are visible on the X-rays. And if you can see that small beads are there on the posterior part of the rectal applicator of the spacer, and those can be seen in an X-ray, and you can usually know the dose at which point what is it is getting. So coming to the next question. So this is the Fletcher suit. That was the answer of it. So the next question is, what is this? So it's an intracavitary applicator with some needles, as I can see, and it's definitely not like the Fletcher suit. So what applicator is this?
Sir, this is a Vienna hybrid intracavitary and interstitial brachytherapy applicator.
Or in other words?
It is a hybrid applicator.
So it's not a true hybrid, but yeah, definitely it is having some option of putting few parametrial needles to the medial parametrium. There is no option of putting needles beyond the medial parametrium. So it's a ring applicator, you should tell like that. and it's a CT/MR compatible because you can see it is not the usual materials of stainless steel it is used. So CT/MR applicator which is used for boosting the medial parametrium in case when it is required. So the next question will be, so it is mostly similar to the previous one, but it is instead of ring, it is having an oval. So identify it. The
So
two.
first image on the right side is showing Utrecht hybrid applicator, sir. And the image on the left side is showing Geneva hybrid applicator.
So how do you differentiate these two?
Sir, in Geneva applicator, the fixation will be with the, sorry, in Utrecht hybrid applicator, fixation of the ovoids will have a screw mechanism, whereas in Geneva applicator, the fixation of the screw is a click and fix method.
Okay, so it's a modified new version of it. Electra is providing the Geneva applicator upgraded version. So it can be used in hybrid applications and CT/MR compatible as usual. And the specially designed needles are used for those to boost again for the medial parametrium. So it doesn't have an option of boosting the lateral parametrium. Okay. Now coming to this. So another extended version of it by Electra. So what is this?
This is Venezia hybrid applicators.
And what difference can you tell us from the previous applicator?
Sir, this applicator have additionally perennial templates.
So if you observe the applicator nicely, so the first part of the applicator is very similar to the previous version. Then we have a vaginal sleeve. We can boost the upper 2/3 of the vagina or certain part of the vagina with this help of the sleeve. And we also have a interstitial, that is the mupute like thing added on it. So it's not an absolutely mupute, but a part of the mupute design has been adopted. So you can perform a total real hybrid application with this, where the medial and lateral parametrium can also be boosted. So this the mupute part of the applicator or the extended part can be used to boost the medial parametrium, the lateral parametrium, and the lateral. After boosting the lateral part, the medial can be boosted through the medial parametrium needles as before. This part, if there is extension of disease inside the upper 2/3 of the vagina, it can be also boosted with this help of vaginal sleeves or caps. Coming to this, so what is this now?
This is tulip hybrid applicator, sir.
So tulip applicator. So the difference.
This applicator have vaginal colpostrates which are moldable as per the patient's anatomy, and this also have templates for interstitial needles.
So it's just a modification where if you see in the blue part of that is the mold, it tries to conform to the upper third of the vagina. You know, it's very irregular sometimes, and it's sometimes roomy, sometimes stenosed. So those part can be used, those part can be molded with the help of this blue color molds, and the needles definitely it will boost the medial parametrium. As you can see, the lateral parametrium again is not boosted. So coming to our age-old applicator, what is this?
This is the Sayed Neblet template.
So a version which was used for perennial template and used for quite a long time, and it's still used by many centers. Sayed Neblet template. And it can be to complete the total interstitial brachytherapy. There is no much option of doing hybrid brachytherapy out here. Okay, so different parts are there. So we'll not discuss the operator part, the vaginal cylinder, the needles, the template, and the stillets to make the needles rigid. Okay. So coming to the next, it is known as
MUPIT, sir, which is Martinez Universal Perennial Interstitial Template, sir.
okay. So combining the previous this applicator and the previous applicators, what are the indications of those?
So the fire nebulate template is used for gynecological malignancies, cervical or vaginal or endometrial malignancies. Whereas MUPIT is an universal template, sir. So it can be used for along with gynecological malignancies. It can be used for prostate malignancy, rectal malignancy, or urethral malignancies also.
So if you see these MUPIT holes, how can you describe these holes? Can you tell me what is the angulation, what is the diversion, and others?
So in MUPIT, we have oblique needles also, sir. That is 13 degrees oblique needles to cover the lateral parametriums.
So I can see there are multiple holes out there, and these can be used to guide the needles inside. It is if you can see if anyone has a MUPIT applicator with him or her. So there are the holes are obliquely designed. So few of the holes are straight and few will be going about a 13-degree diversion to the lateral parametrium. The idea is nothing but to boost the lateral parametrium to its adequate dose. Compared to the side neblet, how can you compare the 13-degree diversion in the side neblet and this?
Side neblet is more parallel interstitial needles, sir.
So we don't have much diversion out here. So instead of that, we can use this holes to when required. If someone wants to boost the medial lateral part of the parametrium in certain scenarios. So you have three holes out here. Or if you orient it nicely, there is an anterior part, there is a hole, the middle, the central vaginal thrombus, the cylinder goes in, and the lower posterior part, there is another hole. What are these holes for?
Sir, one is anterior most is to stabilize the template, sir, and posterior most.
Sir, sorry to interrupt you, sir. We cannot hear Dr. Priya's voice.
One second.
Anterior most.
You can hear?
Hello, am I audible?
Yeah, clearly.
Okay, thank you. Anterior most is for to stabilize the template, sir, and middle is for the vaginal cylinder, and posterior most is for rectal rectal malignancies or prostate malignancies.
No. So the superior, that is the anterior most part of the that is the bigger holes. If you see, that will be mostly for the periurethral brachytherapy. If you are not doing the periurethral brachytherapy, you can just pull out the catheter through that. So the central, you know, it's for the vaginal cylinder, and the posterior hole, the bigger one, is for the anal canal, and the rectum. So you have a separate, they didn't show us here. So you have a separate cylinder type with the constriction and in the being inserted through that posterior hole. So for that perianal brachytherapy or someone interested in doing the rectal brachytherapy, those central cylinders can be used. Okay. Now, if I can ask you, what is the suppose if you've seen the Venezia applicator, you have seen the MUPIT applicator. So how can you differentiate the dose distribution between these two?
Certain Venezia applicator, since it is a hybrid applicator, it will have dose distribution of ICRT along with parametrial distribution also, sir.
No, that is what I didn't want to. The question is different. In the hybrid applicator, that is the Venezia one. You can get first you can design a pointed type of distribution, okay, like the our olden age pointed distribution, and then as you know, you have already drawn the contours in the MRI, you know, and you know what is your HRCTV, you know what is your intermediate risk CTV. So accordingly, you can activate the needle in which area it is required, okay, up on and above the pointed distribution. That is what usually people will do. But in case of MUPIT, there is no concept of designing a pear-shaped pointed distribution type of isodose. Instead of that, we contour the entire thing, whatever is required, and define the dose or the prescribe the dose according to the contour. So pointe type of distribution, it should not be done out here, or it cannot be done. Okay, because we don't have any ovoids, we don't have any ring out here. So to define the pointe. So I'll take few minutes more of this because this part is important. What will be the problems? Suppose you have a Venezia, you have a MUPIT, and a patient is suitable for interstitial brachytherapy. So which applicator you will like to do use and why?
Sir,
In an intact uterus, of course.
I would like to use a hybrid applicator, sir, because I can have a pointed distribution along with can optimize the dose for the residual parametrial disease.
So what is the usefulness of pointed distribution over non-pointed distribution? Or why you want a pointed distribution to be there? Okay, so the interesting part of pointed distribution is any pear shaped. If it is, you can see the pear, the pointed, you will see as the point is defined 2 centimeters above and lateral from the flange, the ABS guideline. So you see whatever the prescription dose is there along the point. Okay, that doesn't. So it means in the center of the distribution, the dose reaches about almost 3 times the point A dose. Suppose point A you are giving 7 gray, the center of the applicator or the central of the uterus where most of the hypoxic cells can be there, it almost gets 18 to 20 gray or more. So that type of distribution is not possible with this MUPIT type of applicators. Okay, so that is the important point you should remember, and all the students also should remember. So that is the basis of developing this hybrid type of applicators, so that we can have the advantage of both point A and the interstitial. Okay. The second point being in the MUPIT, everything, whatever is there in the parametrium needles is there. So you cannot control the distribution. You have to somehow activate many needles in the parametrium which is gone inside the tissue. Okay. I am talking about the needles which has gone not inside the uterus or the lateral parametrium, but medially into the tissue, lateral into the tissue. But here, if you see the golden rule is not to give more than 15% dose with the help of from the needles. The most of the dose should go from the applicators which has not punctured anything, or punctured any tissue or damaged any tissue or the intracavitary thing. And 85% of the dose ideally should come from that, and another 15% should go from the needles which have gone into the interstitium. So that advantage is not to be found in the MUPIT, but it is widely found in the hybrid applicator, that is the Venezia applicator. So coming to the next one. Okay, so we have one, describe this.
Sir, this is perioperative interstitial flexible multi-catheter interstitial brachytherapy of breast, sir.
So how many planes are there?
Sir, I can see 3 planes, sir.
So you can see about 3 planes out there. And what do you think? What have been the indication for this?
Sir, it can be for early breast cancer, sir, for as a modality of accelerated partial breast irradiation or breast post breast conservative surgery boost also, sir.
So it could have been a boost, but and also a PBI scenario. So where the So what if you can tell me, elaborate on what is the difference between PBI and APBI?
Sir, APBI is accelerated partial breast irradiation, and whereas PBI is partial breast irradiation. Partial breast irradiation can be given as a conventional or moderately fractionated or hypofractionated regimen, sir. Whereas APBA is given as a hypofractionated regimen, and the treatment time is also reduced, sir, compared to like APBA. The treatment time should be less than conventional standard regimens.
So usually the word accelerated means the treatment is completed very fast. So usually we complete it within a period of 5 days. And we give the doses morning and evening schedules is a interval of 6 hours in between for more normal tissue repair. And PBI usually we continue for minimum of 5 to 10 days, but not in the twice a day sections. Okay. So what are the various techniques? So we have discussed those. What are the patient selection criteria? So tell me the first question. What is the patient selection criteria for breast brachytherapy?
Sir, as per Astro, patients are divided into 3 categories, sir. One is suitable category, and other is cautionary category, and the third one is unsuitable category. It based on the tumor size. If the tumor size suitable category patients are with the tumor size up to 2 centimeter, node negative cases, LVSA negative, margins are negative, and the ERPR status is positive, and the age is more than 40 years, sir.
So usually LVSI positive and node positive cases usually is not done, and size more than 3 centimeter is a bit cautionary and never to be done over size over 4 centimeters and others. So there are various guidelines. There are ISTRO guidelines. There are NCCN guidelines. There are Astro guidelines. So we can definitely use any of the guidelines and proceed for such cases. Coming to the next one. This one looks interesting. What is this? Of course, the name is written inside the applicator. Yeah.
This is a mammocyte balloon catheter, sir.
It's not actually, it's a cartoon, I think. It's not an original photo. Huh?
Yes, sir.
Yeah. So, mammocyte. So, one of the first olden applicators where breast brachytherapy was used. And can you tell me what dose was given in that?
Sir, mammocyte is used to deliver post BCS boost dose, sir. 12 to 18 gray single fraction they is used to be delivered, sir.
Any disadvantage?
Sir, mammocyte, if we can see, it is a single lumen balloon catheter, sir. So dose optimization is comparatively restricted, sir. And because of the balloon, there is a higher surface dose, sir. And more dose to the chest wall region also.
So you cannot control the doses. So whatever is going through the single applicator, that dose at whatever 5 millimeter, 1 centimeter, you have to accept the dose or the surface of the balloon. So there is no way of controlling the doses in the different parts of the cavity. Okay. So the complication arises because sometimes there is a very high area of hot spot and there is an area of cold spot. So recurrences and necrosis go side by side depending on the scenario. So this applicator has been redefined, redesigned, and it comes to the second one. What is this?
Sir, this is Contour multi-channel balloon catheter brachytherapy applicator, sir.
If I go to the next one, What is this?
This is a savvy applicator, sir.
So what difference do you find between these two?
Sir, difference between Contour and Savvy applicator is Contour is balloon brachytherapy applicator, sir, whereas Savvy applicator is a multi-channel volume-based applicator, sir. So the Savvy applicator is more compatible with distorted tumor bed areas, tumor bed cavities, sir.
Any more points you can tell regarding the number of catheters?
Sir, compared to Savvy applicator, Contour have a limited catheter, limited lumens and limited catheters. So, and the dose and they are also in the center. So, they have limited optimization compared to Savvy applicators.
So in Contura, there are central channel, single central channel followed by 4 in and around. So total of 5. Okay, and it's is connected with the suction also. So you can remove any air or fluid inside the cavity before treating. Whereas in the Savvy applicator, you have about 10 catheters inside, and these are more rigid. These are not as flexible as the Contura. And Contour, you have a balloon out there. You don't have a balloon here. Okay, so the applicators only gets conforms to the shape. It's very complicated applicator, and because each and every applicator you have to the tubes you have to interpolate in the CT scan, and then only the dose distribution is achieved. So a less complicated, of course, is suction and removal of the air and fluid, and a more complicated but more number of points or optimization points can be delivered through these applicators. Okay. So both use remains like the Mamoside only, PBI and Boost. So we'll not discuss about those because the standard indication remains. So least used, but you can have an identity of this applicator. What is this?
Sir, this is a clear path clear path multi-channel multi-lumen applicator for breast cancer, sir.
So it's also the same. There is nothing much difference. So it's another design. And if anyone interested, you can remember the name. It's a clear path, Sabi and Mamosite. Another is Contura. Okay, these are the 4 things that are used with the bracket. So coming to the next one. So this one looks like a silicon applicator. What is this?
Sir, this is a Rotterdam nasopharyngeal brachytherapy applicator, sir.
So olden days it was used. After the invent of when IMRT, I don't think, and proton era, not much of this are used these days, but definitely it was a life-saving tool in recurrent cases or boosting the tumor in olden days. So the Rotterdam applicator for nasopharynx. Can you name another Rotterdam applicator?
Sir, there is one more Rotterdam intracavitary brachytherapy applicator, sir, used for gynecological malignancies.
The fixed geometry one. Okay, so you should always tell it is a fixed geometry, the Rotterdam, and this is another Rotterdam for the nasopharyngeal brachytherapy. So we have about 4 things out here. Upper left corner, what is this?
Sir, this is a custom-made surface mold brachytherapy applicator, sir. Used it is for hard palate malignancies, sir, with catheters in situ, sir.
So usually the palate, the molds are made, and it is made usually by our dentist or any hospital. The dentist can make it, or anyone radiation oncologist interested in it can do it, the hard part. And if you see, there is a small ring-like metallic insert. So what we try to put it so that we demarcate the tumor nicely, because these small tumors, once you do put the applicator inside or the mold inside the hard palate and fix it and do a CT scan, these small lesions, which are very usually superficial T1, T2 lesions, are usually not visible on the CT scan. So that's why you need to have a definite marker or localizer to know where the lesion was. And based on that lesion, the localizer, you can prescribe your dose or draw the GTV and CTV and prescribe the dose. Okay. So it can be used as a radical and also a boost after EBRT. Contraindications.
Sir, contraindications, thickness more than 1 centimeter, or involvement bone.
Contraindication, there will be relative and absolute. So absolute contraindication will be invasion of bone. Any invasion of bone, you should not use this type of treatment. Okay, and better to go for surgery or other surgical colleagues and boost it with go for external beam RT, adjuvant external beam RT, CTRT or external beam RT. If the lesion is very thick, you cannot usually use it. It's not an absolute contraindication, but you can boost the lesion with external beam RT, reduce the size, and go for boost brachytherapy with the help of this type of molds. Okay. Now in the image B, I can see a skull, of course, and over the skull there are certain things drawn. What are those? The green ones, the lines.
Sir, it is showing RT planning reconstructed catheters.
So maybe it was a case of squamous cell carcinoma of scalp. I don't know whether it was radical or adjuvant. I am not sure, but definitely it was used for as a surface mold. It is not looking like a interstitial applicator, and I can see the orphits also. I think that's part of the orphid also there. So definitely it's a mold for the scalp. Coming to the what is this? So left lower corner, you can see a mold. Though it is difficult to tell what it is, but can you highlight on?
Sir, this looks like a custom-made surface mold designed for penile carcinoma, sir.
It looks like a penile carcinoma case. So surface mold, someone has used to do the surface mold. But personally, I am not in favor of doing a surface mold for penile because interstitial gives me a better dose distribution. Can you tell me so dose distribution between a surface mold and interstitial, and how do you, which one is better?
Sir, depending on the tumor depth, if it is less than 1 centimeter and the place area is easily accessible, surface mold for external disease, for external lesions, surface mold provides better dose distribution with good sparing of normal tissues, sir. If the lesion is more than 1 centimeter and if it is more than 1 centimeter, then surface mold won't be able to provide adequate target coverage. Sir.
So the thing is, surface mold will always deliver the dose above the tumor. Okay, so it is not designed to deliver the dose inside the tumor. Contrary to that, interstitial brachytherapy is designed to deliver the dose from inside out. Okay, so if you are interested in doing a surface mold, or you think a lesion is suitable for surface mold, a combination of mold and interstitial can be done. So sometimes we have done those, and these gives us much better dose distribution. And sometimes in case of surface mold, you have to drag the isodose. You call it dragging the isodoses because adequate isodose is not covering the gross tumor volume of the surface mold. So that lack can be an advantage if you add another interstitial needles under the surface mold. So combination of both can give us a much better precise distribution of dose if at all someone is interested in doing mold brachytherapy in certain cases. Okay. So coming to this, these are pictures you can easily describe. So tell us, what is this?
Sir, The image A is showing a perioperative procedure of multi-catheter interstitial brachytherapy application, sir.
So maybe it would have been a sarcoma or something, you know. On the site we cannot know, you know. So what should be the intercatheter distance, the planar distance between these catheters?
Sir, interplanar distance should be at least 1 centimeter, sir, and intercatheter distance as per Paris system, it should be at least it should be more than 0.8 to 15 mm, sir.
So 0.8 to 1.5 centimeter, but we usually tend bigger the volume, we try to keep it at 1.5 centimeter. Smaller volume, we tend to keep it at 1 centimeter. So certain cases maybe judged on the number of catheters also. So here the superficial plane, I think it's a little bit more than 1 centimeter. Depending on the catheter use also, I think it was defined. So anyway, so this type of treatments can be defined or what is the advantage of doing interstitial brachytherapy for this case? Suppose it was a sarcoma somewhere in the back.
Sir, we can provide, we can do dose escalation, sir, by using brachytherapy with good normal tissue sparing compared to EBRT, sir. And if it is a pediatric sarcomas, they'll have benefit of less normal tissue effects, and they'll less exposure for radiation also, sir.
So as he shared, as he told, it is for, can be used for radical and also for boost. Okay, so most of the time is used as a boost, and sometimes we use for radical purpose also in pediatric cases, as she has rightly told. So what are the different dose schedules? Can you tell us for the boost or for radical?
Sir, as a monotherapy for radical, we can go for 60 to 66 gray, sir, at 4 gray per fraction with twice daily with 6 hours gap, sir. Whereas in boost, based on the resection status, sir, if it is R0 resection, 10 to 12 gray to be should be delivered, and if it is R1 resection, 12 to 15 gray should be delivered, and in case of R2 resection, 15 to 20 gray should be delivered, sir.
So, in the boost setting, this patient particularly, we used a dose of, we didn't want to go above 4 gray. So, 3.5 gray was used, 3.5, 3.6 was used per fraction. And it was given twice daily. And we are planning for about 6 to 7 fractions, coming to a dose of approximately 22 to 25 grays for the boost. And after that, we'll be giving external beam RT of about another 50 gray. So the total dose shoots up to 70 to 74, which is very good dose for a sarcoma. So part of the tumor was grazing the nerves. So care was taken not to put implant directly over the nerve, which you should always avoid directly to the nerve, directly to the vessels, directly to the bone. This should be avoided. The puncture points or insertion points should be far away from the skin. It should not come to the area where the stitch or the stitch is given, because we do not want any healing problems with it. So usually in the surface of the isodose stays a centimeter away from the skin. Okay, so that's it. Coming to the next. So this one, image A and image B, two different scenario. Describe it.
Sir, image A is showing multi-catheter insertion, multi-catheter interstitial catheter application for lip malignancy, sir. And image B is showing multi-channel, multi-catheter implantation for mostly right buccal mucosa, sir.
So tell us the planes also, number of planes in A, B.
Sir, in image A, it appears like two planes were done, sir, and whereas in image B, it appears a single plane application, sir.
So definitely. So yeah. So any lip lesion, very early on, up to 2 centimeter, 2.53 centimeters, you can go for brachytherapy, interstitial brachytherapy, radical one. So because of surgery, sometimes it's quite dysfunctional. And in the second case scenario, angle of mouth, definitely you should go for non-surgical approach whenever it is feasible, because microstomia becomes a very problematic issue for the patient after the tumor is cured. So the dose we will not discuss much. We have discussed before. So ideally, EQD2 of 60 to 66 grays can be delivered to such scenarios after drawing the CTVs. You can go for dose homogeneity index. It's in JAK-ISTRO guidelines are there. Everyone can go through it. So 0.7 is quite a good index for that, where the hotspots can be avoided. So ideally, you should not try to mix up. So around the applicators, the 150% is there, and these applicators should not. It should not be joining with each other. So small 150% isodose line around the catheters is allowed, but two catheters 150% should not join. Describe this.
Sir, image A is showing multi-catheter application, interstitial application for penile malignancy, sir.
Yeah, it is a multiplanar implant, and to tell you, it was a T2 tumor, and it was not invading any corpus or the urethra, and it was not going to the uh, the skin, not crossing the corona. So such cases, interstitial brachytherapy is quite feasible. You should always rule out lymph nodes, LVSI, before doing such procedures. So the dose, it remains constant, it differs. So you calculate the EQD2 and don't try to exceed more than 4 gray per fraction. So 3 to 4, 3.5 is quite a good number. So per fraction. So side effects are much less with this. So what are those? Identify this source. It's developed by BARC.
Sir, this image shows ruthenium 106 episcleral plague, sir.
Any indications?
Indications are most commonly pterygium and choroidal meningiomas or choroidal hematomas or hemangiomas or retinoblastomas, sir, in early stages when focal therapies fail.
So it's not done in much hospitals, but definitely few hospitals are doing it in India, and BARC is developing it, and it remains one of the useful radionuclide for treatment of eye malignancies, as she has correctly told, in choroidal melanomas, squamous cell carcinomas, some orbital mats, retinoblastomas, the superficial ones can be easily treated with this. Okay. So coming to, so we have a very interesting thing here. So everyone should know that. So it's point A, point B, rectal and bladder ICRU points. Define those.
Sir, point A as per ICRU 38, it is a reference point, sir. There are multiple point A definitions, sir. The first is from point A is a reference point from a mucosa of the lateral 2 centimeter superior to mucosa of the lateral fornix and 2 centimeter lateral to central uterine tandem, sir, in a centralized uterus. And it is further revised to it is further revised to a point which is 2 centimeters superior from external os or flange and 2 centimeter lateral from central uterine tandem, sir. And further, it is revised by Todd and Meredith as from 2 centimeter from lowest uterine source to 2 centimeter lateral from central uterine tandem, sir.
So there are various definitions of point A, as she has correctly told, starting quite early to the recent the ABS guidelines. So we have different definitions of point A, and what is when they made point A? What was the concept of making point A?
Sir, point A was made as a reference point to limit the dose, sir. It is a paracervical reason. They have noticed if your a dose limiting point, if it is crossing more than 80 gray, they have noticed there is a necrosis on cadaver specimens, sir. So from then, point A was made as a reference point, dose limiting reference point.
So what is point B?
Sir, point B is a reference point for absorbed dose of obturator lymph nodes, sir. It is seen on AP image 2 centimeter. It is 2 centimeter superior from external os and 5 centimeter lateral to the central uterine tandem, sir.
So it was used to know the lateral pelvic wall dose or the dose to the pelvic nodes. Okay. So point B is relatively fixed point, and but point A is not supposed to be a fixed point. So sometimes the problems. Can you tell me some problems of defining the dose with point A?
Sir, point A is can only be defined when uterus is in centralized, sir. So any movement in uterus can shift our point A, sir. And it depends on our position of ovoids also, sir. So it anatomically with the patient to patient it can differ, and it can change with interfraction also, sir.
So yeah, that is correct. In addition to that, sometimes if you take the ideal condition also, sometimes in very thin uterus, the point A comes sometimes inside the intestine or sometimes inside the bladder also. So it's an unavoidable circumstance. So it happens. We have seen whenever we try to do things with CT scan, this is a we used to see the point A coming inside the intestine or the bladder. So these are the various disadvantages, but it has remained for last 70, 80 years point A. Still now, many centers will be defining the point A, and ICRU has not discarded it yet. Okay. Coming to the rectal and bladder point, how do you define in the diagram? It's in the blue diagram. How do you define it?
Sir, rectal point is a difference point for absorbed dose of rectum, sir. In this picture, it is a lateral view. In lateral view, rectal point is defined from the lowest uterine source or ovoid source. If you are drawing a line posteriorly, the posteriormost point on the vaginal posteriormost point along the lowest uterine source. From there, 5 millimeter posterior to the vaginal from the packing, and posterior vaginal wall need to be visualized to assess rectal points. So that is visualized by using contrast gauze packing.
And what is the amount of bladder contrast that is given to define the bladder point?
Sir, 7 cc contrast will be used, sir.
Okay. So different brachytherapy systems. These are the various systems that was there in place, and if you can, two types of implants are there. First one is a planar implant, and there are volume implants. So I'll be asking questions on what is the meaning of capped and uncapped.
Sir, in planar implants, capped ends will have a uniform distribution, sir. Whereas in uncapped ends, there will be a loss of uniform distribution. If there is only one end of the implant is uncapped, there will be a loss of 10% uniform distribution, sir.
So if you see, there, you can see source anisotropy. The self attenuation of the sources in the longitudinal direction produces a dip in the isodose in this curve. Okay, so this type, if you are not putting any crossovers here, so what happens is this dip remains. In the olden ages, when the CTR was not there, so and nowadays we can see these dips with the help of CT scan and softwares. The software will tell you how much dose reduction in the surface is there, or the depth is there. So they used to put capped ends at the anterior and posterior part so that a uniform distribution can be achieved. Okay. Now, another point being, what is the basal dose? What is BD, BD1, BD2, BD3? What does it mean?
Sir, basal dose refers to the mean of the arithmetic mean contributed by all the sources in this equatorial triangle, sir, from different planes.
So you can see these triangles, equilateral triangles, ideal dose, ideal insertion. Whenever there is the ideal scenario, these dark dots are the needles, you know, and these dots make add up and make equilateral triangle. All sides same, and the center of the equilateral triangle we define a point, and that is the basal dose for that triangle. So you add up all the basal dose depending on how many implants or the sections you have, and add up and divide by the number of the points. So you get a reference dose. So that is the reference isodose line. That should be coming, and 85% of that is the prescription. Okay, so it's very simple in olden days, but nowadays computerized dosimetry is there. So these things doesn't apply much, but to do a good implant, you should always remember these points. Okay, and maintain the equilateral triangle type distribution in all the implants you do. Another point is the basal dose is always calculated in the central plane of the implant. Okay, you can calculate multiple planes, but ideally in the central plane. Okay, so interesting applicator. What is it?
Sir, this is a Rotewire applicator, sir.
Used for?
It is used for radical endometrial carcinomas, which are medically inoperable cases, sir.
Okay, so the roti Y applicator, and why do you think the Y horn, two horns of Y are there?
Sir, these two horns are used to provide adequate target dose coverage to fundus and cornua of endometriomas.
So it's a good answer. So, and what point they define the dose? Like point A in cervix, what points are there?
Sir, in endometrium, we have point S, point W, and point M, sir.
Okay, very good. So sometimes the point is started from the point M means myometrium. So instead of going from the cervix, they go from the top end. Okay, and 2 centimeter stays the rule. It's done in cases of radical endometrium where surgery was not done or not possible, or the patient doesn't want surgery. The anesthesia, giving anesthesia is difficult for the patient. Many of the centers or the consultants will prefer chemoradiation in certain cases. Okay, after EBRT, this type of brachytherapies can be done. Okay, so what are those applicators? Top three and the bottom one? Yeah.
Sir, top three applicators are single lumen intravaginal cylinder applicator, sir, and last applicator is intravaginal multi catheter multi-lumen intravaginal cylinder applicator, sir.
Okay, so top 3 is a single lumen and acting like a central vaginal sorbo. You define the dose in the single catheter depending on 5 millimeter into the vaginal wall or on the surface of the applicator. The fourth applicator is the multi-channel, same thing with other channels, additional channels. So if you compare these two, which type of insertion, which applicator do you want for your personal use?
Sir, multi-channel applicator have more optimization capacity, sir, and it is can be moldable for according to the patient's vaginal anatomy also, sir.
So multi-channel applicator means we have multiple points of optimization. So more number of points I have, more options of giving a higher dose to the certain part or reducing the dose from the OS stays an option. So always multi-channel applicator, if it is possible, we can use it. So these are very old images. If you can identify this.
Sir, this is Stockholm's intracavitary brachytherapy system, sir.
So Stockholm system, it's a very old system, and it was, of course, not used nowadays, but it has been a primary basis for the present brachytherapy systems, brachytherapy we do. So this is also an old one. Can you tell me what is that?
Sir, this is a Paris system intracavitary applicator, sir.
So Paris system intracavitary, if you can, if you get it, I hope they don't give you, but if you get it, you can write as a Paris system intracavitary brachytherapy. They have their own systems in those days. So each hospital or center will develop their own system and give name accordingly. But fundamentally, this all has led us to the present. Lot of applicators these days we seeing are fundamental design always exist. Those systems are there in these present applicators. Manchester system they used like this. So different types of systems. I'll go back again. So Stockholm system, the Paris system, the Manchester system. So just remember those things. Details question will not be asked on those. I hope it doesn't ask. But what is this?
Sir, this is multi-channel template-based breast applicator, sir.
So template breast brachytherapy. If anyone is not interested in doing flexible implants, they can go for this template-based implants. Advantage.
Advantage. Catheter positions will be fixed. Source position
is always maintained. So geometry is always maintained in this type of templates because you have fixed holes. So as long as you are inserting through that proper guided A1, A2 holes, so same holes, the alignment, the geometry always remains like an equilateral triangle. Okay, so that is the advantage. The disadvantage being the patient has to roam around with this. It's uncomfortable for the patient. Okay. So another interesting one used frequently these days.
Sir, first image is showing stepper prostate template, sir, and second image is showing Martinez prostate template, sir.
So it can be used for prostate, but not as a single. It can be mounted with an ultrasound guidance, and then actually a total system exists for that. And freehand, please do not go for freehand with this type of templates. always use the ultrasound guidance for this. If I want to ask what are the doses
Sir,
for boost
uh,
with HDR?
with HDR booster, dose regimens will be either 15 gray in single fraction or 9.5 gray in two fractions can be delivered, sir.
Yeah, 9.5 gray in two fractions can be also given, but usually many people will be giving 15 gray in one fraction. Okay. So after external by MRT. What are these?
Sir, this is a Leipzig applicator, sir.
Used for?
Used for this is a surface applicator, sir. Used for superficial squamous cell carcinomas, basal cell carcinomas, or keloids, sir.
So surface applicator with the shield and cup, you know, the transfer tube is connected through this and is opened and connected, and this the shield protects the adjacent structures. Okay, remember this one. So Leipzig applicator used for superficial carcinoma of the skin. So almost like the previous question, we have seen it before. Name of this applicator.
Sir, this is a Miami applicator, sir.
So Electa has designed this applicator. The uses remain same. We have already discussed in details before. So tell us about the first diagram.
Sir, first diagram is showing target volumes, sir. You can see GTV and HRCTV and IRCTV, sir.
So when you are supposed to draw GTV in brachytherapy for CS cervix?
In radical cases, sir.
It's not like that. So whenever you have an MRI, it should not be done with the CT scan. Whenever you have MRI, which sequence of MRI you will be using?
Sir, T2 weighted MRI sequence we will be using.
So T2 weighted MRI sequence should always be used for drawing GTV in cervix. Post EBRT, the scenario can be different scenarios exist as per Jack Stroh. First scenario being no disease at all. Second scenario being disease limited to the cervix only, and third scenario being the disease which has not improved at all. Partial response, complete response, and increase in the size of the lesion. So these different scenarios we can draw the GTV. So if suppose you do not have any GTV, there is complete response after EBRT. So what is the HRCTV?
In case of complete response post EBRT, HRCTV should include the entire cervix, sir.
So entire cervix is the HRCTV, and so in other words, the definition of HRCTV is any GTV present along with the cervix. So whatever in MRI is there, gray zone is there, whatever problems you are having in differentiating the lesion, those areas can be identified as a HRCTV. Okay. So what is the concept of IRCTV in brachy?
Sir, IRCTV includes pre-EBRT disease extent, sir. So in brachytherapy, IRCTV should include pre-disease extent that includes HRCTV and with margins of 1 centimeter craniocaudally and laterally and 5 mm can also be extended till 15 mm in the potential disease spread of disease, sir. And IRCTV should receive 60 gray altogether from EBRT and brachytherapy, sir.
So dose part is still debatable, but definitely 60 gray at least should be given. Now another part is suppose the disease in the initial stage, it was limited to the cervix only. A small 1 centimeter lesion in the cervix and after you have given EBRT and EBRT, after EBRT there is no disease. So what is the IRCTV?
Sir, now my IRCTV will include entire cervix with additional safety margin of 1 centimeter craniocaudally and laterally 1 centimeter and 5 mm anteroposteriorly, limiting to rectal and bladder walls.
Okay, so that's it. So HRCTV and IRCTV concept, you can go through the Jackie Stroke guidelines also. So you'll find a detailed um, definition of those volumes. Now, coming to the next one, I will not ask you what is this, but what is this not procedure, what is this applicator called?
Sir, this is a Freeburg flap applicator, sir.
So is can be used in the skin, okay, can be used in parop HDR brachytherapy as giving the usually used in which type of cases, for which type of implants or parop cases you will be using this type of Freeburg applicator?
Sir, for flap cases, sir, where to provide perioperative boost volumes, any sarcomas or breast also you can use, sir. This is a
Breast people will not use. It is used. It was used, I should say, in cases of pancreatic cases after resection. When you think it was an positive margin, or certain cases of stomach cancers, it was used. Not much used nowadays, but it has been used quite a lot in the olden days. The toxicity being neurotoxicity, because giving about 18 to 20 gray high dose develops a significant neurotoxicity in certain patients. The name being Freeburg flap applicator. So, what is this? It is not much clear, but someone who has seen it can tell it.
Sir, this image shows two intraluminal brachytherapy applicators, sir. On the right side, on the first image, we can see intraluminal brachytherapy applicator for esophagus, sir, with esophageal bougie, and the second on the image, the other image shows endobronchial bougie and with intraluminal brachytherapy catheters, sir.
So esophageal brachytherapy not done nowadays much, but definitely used to do it earlier. So can you tell me one or two indications?
Sir, as a post EBRT residual boost or can be given, sir, in esophagus, sir. Whereas endobronchial brachytherapy often used for palliative settings, sir. In case of endobronchial obstruction or hematemesis, hemoptysis, sir.
So it was used as a palliative procedure also, sometimes boosting after the esophageal bougie. So it was used, but it had certain contraindication and some stricture incidence, some perforation was very high. So many of the centers has abandoned it after the cross protocol has come into existence. And the radical dose has gone down from 60-64 to 50-5040. So hardly used nowadays, but still in cases of recurrent cases or esophageal obstruction, hemorrhages, many centers can still use it, and someone not suitable for not a full dose of paclicarbo, weekly paclicarbo is not suitable. Certain cases can be used for boosting the dose till 60 gray. Bronchial as much not much used, but still you should know in cases of bronchial hemorrhages, it is can be used. One of the thing these days after the advent of CT guided planning systems, not much used, but was used earlier quite frequently. There are certain contraindications of using esophageal brachy. One of the thing being lesion size which is more than 1 centimeter, and it has gone to the bone or any other structures. 1 centimeter being because you cannot prescribe more than 1 centimeter from the bougie. So that is the reason you can these are contraindicated. Many centers does a Riles tube insertion and brachytherapy with the help of Riles tube also, but alert is a point against it because there is very high mucosal dose if you do a Riles tube brachytherapy. The esophageal bougie is a tapering one. If you see the smooth, the lower end is very tapered and the upper end is broadened, so it expands the esophagus, and even it makes the esophagus adhere to the esophageal bougie. That's why it tends to give a very circular dose distribution to the esophagus. Whereas in Ralph's tube, it can be one-sided. It because the esophagus lumen of about 1.5 to 2 centimeters, it can be on one side of the esophagus, and hardly it remains on the center. So this type of problems, so mucosal toxicity becomes very high if you are giving Ralph's tube brachytherapy. So the bougie still remains the standard if anyone wants to do the esophageal brachytherapy. So I think it has come to the end. Am I audible?
Yes, sir.
Yeah, actually the slide we have finished it. No more slides are there to be discussed. Anyone having any questions? If it is late today, I can answer it in the online. Okay. Okay, then I will end it. Fine.